नमस्ते आदरणीय महानुभावहरु। आज हामी चाहिँ नेपाल्स एभ्री न्यूबर्न एक्सन प्लान को बारेमा चाहिँ म यहाँ पठन गर्न गइरहेको छु। गभर्नमेन्ट अफ नेपाल, मिनिस्ट्री अफ हेल्थ 2016। यो फरवर्ड मैले स्किप गरिरहेको छु। प्रिफेसलाई पनि मैले स्किप गरिरहेको छु। एक्नोलेजमेन्ट पनि मैले स्किप गर्दैछु। यहाँले हेर्न सक्नुहुन्छ यो 90 पेजको रहेको छ। वे फरवर्डलाई पनि मैले यहाँनिर स्किप गर्दैछु र टेबल अफ कन्टेन्टमा रहेको छ नेपाल्स एभ्री न्यूबर्न एक्सन प्लान, ग्लोबल एन्ड नेशनल अब्जेक्टिभ फर न्यूबर्न हेल्थ, भिजन, स्ट्राटेजी, डाइरेक्सन एन्ड गोल। 2 मा रहेको छ म्याटर्नल एन्ड चाइल्ड हेल्थ इन नेपाल, पोलिसी एन्ड प्रोग्राम, हेल्थ ट्रेन्ड एन्ड डेमोग्राफिक्स, क्वालिटी अफ केयर। 3 मा रहेको छ स्ट्राटेजिक अब्जेक्टिभ्स अफ NENAP, जसमा चाहिँ हाम्रो 9वटा अब्जेक्टिभ्सहरु रहेका छन्। 1 नम्बरमा चाहिँ रिबिल्ड एन्ड स्ट्रेन्थेन हेल्थ सिस्टम इन्फ्रास्ट्रक्चर, ह्युमन रिसोर्स फर हेल्थ म्यानेजमेन्ट, प्रोक्युरमेन्ट एन्ड सप्लाई चेन म्यानेजमेन्ट। स्ट्राटेजी अब्जेक्टिभ 2 मा इम्प्रुभ क्वालिटी अफ केयर एट पोइन्ट अफ डेलिभरी। अब्जेक्टिभ नम्बर 3 इक्विटेबल युटिलाइजेसन अफ हेल्थ केयर सर्भिसेस। अब्जेक्टिभ नम्बर 4 स्ट्रेन्थेन डिसेन्ट्रलाइज प्लानिङ एन्ड बजेटिङ। नम्बर 5 मा इम्प्रुभ सेक्टर म्यानेजमेन्ट एन्ड गभर्नेन्स। अब्जेक्टिभ 6 इम्प्रुभ सस्टेनेबिलिटी अफ हेल्थ सेक्टर फाइनेन्सिङ। अब्जेक्टिभ नम्बर 7 मा इम्प्रुभ हेल्दी लाइफस्टाइल एन्ड इन्भाइरोमेन्ट। अब्जेक्टिभ 8 स्ट्रेन्थेन म्यानेजमेन्ट अफ पब्लिक हेल्थ इमर्जेन्सिज। अब्जेक्टिभ 9 इम्प्रुभ अभाइबिलिटी एन्ड युज अफ एभिडेन्स इन डिसिजन मेकिङ प्रोसेस एट अल लेभल। टार्गेट फर सक्सेस, जसमा चाहिँ इन्डिकेटर टु ट्र्याक NENAP प्रोग्रेस भनेर रहेको छ र रेफरेन्सेसहरु रहेका छन्। त्यसपछि लिस्ट अफ फिगर पनि यहाँनिर दिएको छ, लिस्ट अफ टेबल पनि रहेको छ। एब्रिभिएसन यहाँले हेर्न सक्नुहुनेछ। यसमा चाहिँ मैले चाहिँ यहाँ स्किप गर्न गइरहेको छु। एक्जिक्युटिभ समरी। नेपाल्स every newborn action plan NENAP set a vision for country in which there are no preventable death of newborn or stillbirth, where every pregnancy is wanted, every birth celebrated, and women, babies and children survive, thrive and reach their full potential. The vision is consolidated by ambitious target to reduce mortality of newborn below 11 per 1000 live birth by 2035 from the current rate of 23, and to also reduce the stillbirth rate below 13 stillbirth per 1000 total live birth from the current rate of 18. The plan is guided by the universal health coverage approach adopted by the National Health Policy 2014 and is integrated within the broader National Health Sector Strategy in 2015 to 2020. Importantly, it further cements the commitment of the Government of Nepal and its partner for substantial improvement in the survival of mother and newborn. Considering that a large proportion of under 5 mortality are newborn death, which are within the first 20 days after birth, the newborn period, increasing investment for improving the survival of newborn through universal access to evidence-based intervention in paramount. Informed by the barrier to deliver critical maternal and newborn intervention proposed by the lesson 2014 newborn series, this plan adopts strategic and intervention to improve availability of quality newborn services at all levels of care, particularly for poor and vulnerable population. NENAP adopts 4 strategic directions or approaches outlined by NSSS: equity, quality, multisectoral approach, and reform. It aspires toward universal health coverage by availing equitable quality health services, particularly at the most vulnerable time in labor, during childbirth, and in first days of newborn life. The plan recognizes that a strengthened health system and persistent collaboration between diverse multisectoral actors are prerequisite to deliver life-saving interventions. Thus, it reflects on the 9 strategic objectives of Nepal Health Sector Strategy and highlight key action to achieve the goal to reduce newborn mortalities and stillbirth by 2035. Specifically, these are rebuild and strengthen health system infrastructure, human resource for health HRH management, procurement and supply chain management. Second, improve quality of care at point of delivery. Third, equitable utilization of healthcare services. Fourth, strengthen decentralized planning and budgeting. 5. Improve sector management and governments. 6. Improve sustainability of health sector financing. 7. Improve healthy lifestyle and environment. 8. Strengthen management of public health emergency. 9. Improve availability and use of evidence in decision making process at all levels. NENAP seeks to achieve its goal through service delivery arrangement that expand maternal and newborn health services from the community to tertiary levels. New evidence-based intervention will be delivered that promote healthy behavior and increase utilization of life-saving maternal and newborn intervention. Based on the lesson of the AMA program, this action plan reduces financial burden to families for seeking preventive and curative newborn services through expansion of free newborn services, including financial subsidies for referral. While NENAP set ambitious goal for reduction in the newborn death and stillbirth for 2035, it remains an integrated action plan within prevailing and future national health sector strategies, and NENAP will be principally implemented through the Nepal Health Sector Strategy 2015-20, implementation plan and the concomitant annual work plan and budget, and its progress will be periodically assessed at sub-national and national review forums. Nepal's Every Newborn Action Plan. Global and national objective for newborn health. There has been remarkable progress in reducing the number of child deaths globally, and in Nepal in recent decades, still 2.9 million babies die every year within the first month of life, and additional 2.6 million babies are stillborn globally. An estimated 23,000 children die in Nepal each year before reaching their 5th birthday, with 3 out of 5 babies within 28 days after birth and the newborn period. The government of Nepal committed to survival of children, thus endorsing the Committing to Child Survival, a promise renewed, and the Sustainable Development Goal that call for ending preventable child death. This translates to the reduction of newborn mortality to 11 and or less per 1,000 live birth by 2035. Achieving the target will require sustained and coordinated effort by all stakeholders. The Nepal Every Newborn Action Plan (NENAP) will guide the sector to achieve this ambitious attainable goal. It put into practice evidence presented in the recent Every Newborn series published in May 2014 that highlight key intervention to reduce newborn mortalities. The 67th World Health Assembly adopted this evidence as part of the Global Every Newborn Action Plan. The inspiration for Nepal and other countries to translate to country-specific strategy and action plan. In Nepal, the newborn working group chaired by the Chief of Planning, Policy and International Cooperation Division within the Ministry of Health and Population finalized the NENAP. The working group consisted of senior officials from various government line agency and development partners. National and sub-national consultation were held for input and feedback to ensure that the plan reflected on the ground realities and strengthened horizontal and vertical linkage. The NENAP is guided by the National Health Policy 2014 and for the first 5 years operationalized through the Nepal Health Sector Strategy 2015-20, and its implementation plan. The MOSP will revise this action plan to be consistent with the prevailing country health sector strategy, and in 2020 will review and update this action plan based on the lesson and achievement of its goal in the preceding 5 years. The plan aspires toward universal health coverage by availing equitable quality health services, particularly at the most vulnerable time in labor during childbirth and in the first stage of newborn life. The plan recognizes that improving health and wellness of mother and newborn is a crucial prerequisite for the prosperous nation, which requires strengthened health system and persistent collaboration between diverse multi-sectoral actors. An integrated and collaborative effort under the joint leadership of the Family Health Division and Child Health Division will lead the implementation of this action plan to ensure the desired changes in the service delivery. New maternal and newborn intervention will be integrated into existing facility and community-based program to facilitate a seamless continuum of care provided to all women, newborn and children. Vision, strategic direction and goals. The MOSP adopts the aspiration vision of the Promise Renewed initiative or NENAP, operationalize the vision through the sustained focus on 4 strategic direction or approaches defined by the NHSS 15 to 20, equitable utilization of health services, quality for all, multi-sector approach and reform, ambitious target to significantly reduce newborn mortality rate and stillbirth in the next 20 years are consistent with the global ENAP's goal. Vision, a Nepal in which there are no preventable death of newborn or stillbirth, where every pregnancy is wanted, every birth celebrated, and women, babies and children survive, thrive and reach their full potential. The strategic direction and approaches. Equitable utilization of health services. Achieving universal health coverage will require sustained effort to reduce barrier to access and utilization of health services, particularly for underserved population. Critical newborn services will be added to the free package of services to increase access to services that are currently out of reach for many. Quality for all. Healthcare services must meet basic standard of quality. It will require effective coordination with facility and across multiple levels of public and private provider that is centered around client need. Strengthening of evidence-informed program and intervention will ensure client will receive services that have the highest chance of success. Multi-sectoral approach. Collaboration with other sector is paramount to improving access to quality healthcare, improving nutritional and educational status, access to clean water, sanitation facilities and healthy neighborhood are critical for the health of mother and newborn. We must reach out to and expand our collaboration with other sectors and partners. Reform are needed within the MOSP to be responsive to the healthcare need of the population and reduce inequalities in health outcome. Decision making, including planning and budgeting authority, will be developed to the local bodies. New opportunity for partnership with the private sector to deliver quality health service will be explored and implemented. Goal. The NENAP aim to achieve a newborn mortality rate of less than 11 death per 1000 live birth and stillbirth of less than 13 stillbirth per 1000 total birth by 2035. Target that will be made in all the province of Nepal. Goal 1. Reduce preventable newborn death in every province to less than 11 newborn death per 1000 live birth by 2035. Goal number 2. Reduce preventable stillbirth in every province to less than 13 stillbirth is per 1000 total birth by 2035. Disaggregating the goal to the sub-national province level aims to reduce the wide disparity that exists between the various regions of Nepal, the hill and mountain area of the far west and midwest region in particular. Okay, you can see the picture here. 23 to 11 and 18 to 13 figure. NENAP project target projection of newborn mortality rate and stillbirth rate. Have Nepal lowest rating on the Human Development Index and Human Poverty Index. The Far West region also has the worst neonatal mortality rate 41 per 1000 live birth and worst under 5 mortality rate of the country 82 per 1000 live birth. The province focused goal of NENAP is ambitious but also critically needed in order to bring most needed attention and resources into this variable vulnerable area. A further challenge is additional vulnerabilities that lay between population within region. Evidence indicates that the annual rate of reduction in neonatal mortality rate is variable between demographic group. For example, between 1996 and 2011, when the national ARR for NMR was 3.3, and the ARR for newborn of the wealthiest quintiles was almost double at 6.2%, whilst newborn of mother with no education was just 2.6%. Thus, the newborn strategy implemented during this period have been effective, but variably so with less advantaged population, slow to decline mortality rate than more advantaged population. Strategy to bring equity in health status of all newborn from all population of Nepal will be a major focus of this NENAP. Maternal, newborn and child health in Nepal. Policies and programs. The government of Nepal has consistently maintained a focus on maternal and child health since the early 1990s, starting with the National Health Policy 1991, which took primary health care communities across the country through decentralized district health system. The second long-term health plan 1997 to 2017, periodic health plans, health sector plans 2004 to 2009, second 2010 to 15, third 2015 to 20, and the recent endorsed National Health Policy 2014 have prioritized maternal and child care, particularly for poor and vulnerable populations. Guided by this national policy, Nepal successfully scaled up maternal and child health intervention through effectively linking community-based care to the health facility. The National Safe Motherhood Policy and subsequently the Nepal Safe Motherhood Program 2002 to 2017 emphasized improved access to quality basic and comprehensive emergency obstetric and newborn care. BMONC and CEMONC increased availability of skilled attendant at birth and strengthening referral services, particularly for poor and vulnerable population. To further improve the survival of children under 5 years of age, a pioneering community-based approach to integrated management of childhood illness was launched in 1997 to improve the survival rate of children under 5 years old. Its main innovation in community health worker that provide first round of treatment and referral for major childhood killer like pneumonia, diarrhea and acute respiratory illness, management of newborn care, that is local bacterial infection and possible severe bacterial infection, was added in 2009 to the ensured issue related to newborn survival will addressed in the IMCI package. In 2004, Nepal became the first low-income country to respond to the stagnating mortality rate during the newborn period through the National Newborn Health Strategy. The government in 2006 recognized the importance of addressing newborn health as an integral part of Safe Motherhood Program, thus endorsed the National Safe Motherhood and Newborn Health Long-Term Plan 2006 to 2017, drawing on lesson from the IMCI and the recent neonatal survival series. In 2007, community-based newborn care package was developed, and after successful pilot scale up to 39 districts by 2013, the package enhanced the capacity of community health worker to prevent and manage critical treatment to newborn and refer complication to health facility, which in 2014 was merged into the community-based integrated management of newborn and childhood illness (CBIMNCI) to further drive synergistic impact of both programs. In order to promote the use of institution for delivery, the Safe Delivery Incentive Program was started in 2005 that provide financial incentive to mothers and healthcare provider for each delivery at health facility. The incentive offset the financial burden of transportation for pregnant mother, which is a major factor causing delays in seeking appropriate healthcare in Nepal. In 2006, the National Skill Birth Attendant Policy 2006 rapidly expanded in-service training for skilled birth attendant, supported by the growing body of evidence that show availability of skilled delivery health worker in reduced mortality. The policy set an ambitious target to raise percentage of delivery attended by SBA from 18% in 2016 to 60% by 2015. Starting in 2014, MISP introduced the application of chlorhexidine gel CHX4% on the newborn and continued to scale it up nationwide by integrating its use with existing maternal and child health programs. The use of chlorhexidine was adopted after randomized trial, including in Nepal, that showed the gel to be effective in preventing infection and improving newborn survival in low-resource setting. Following the second popular movement, the Interim Constitution of Nepal 2006 endorsed basic healthcare as a fundamental right for all citizens, initiating gradual expansion of free essential healthcare service up to the district level. In 2009, the Ama Suraksha program replaced the safe delivery incentive programs and further included incentive to complete 4 antenatal care ANC checkup for timely detection and referral of complication-free delivery, while continuing to expand the availability of life-saving emergency obstetric service through public and private health facility. Today, primary outpatient care, consultation and essential drug are provided free charge up to 25-bedded hospital. Further, ANC and postnatal care (BNC) checkups and institutional delivery, including BONC and CONC in all public and some private facility, are provided free of charge to all citizens, while targeted population group are also afforded free and subsidized specialist care. Health trend and demographics. Declining child mortality. In last 15 years, Nepal has made a significant achievement in the health outcome, particularly for mothers and children. Extraordinary reduction in maternal and under 5 mortality has meant that mothers have notably higher chances of surviving childbirth, and babies born today are much likelier to reach their 5th birthday than in the previous 15 years. The target for Millennium Development Goal 4 called on Nepal to reduce under 5 mortality rate by 2/3 from 1990 to 2015. During this time, it was reduced by 70% from 162 in 1990 to 38 per thousand live birth by 2014. The infant mortality rate (IMR), a probability measure of dying within the first year, has also declined during this period from 99 to 33 per thousand live birth, 67% reduction. You can see in this figure. Here you can see 142 to 38, 99 to 33 and 53 to 23. Declining trend of child mortality in Nepal. The number of children under 5 years age, including infant and newborn, are dying as proportion of 1,000 live birth is decreasing in Nepal. However, the proportion of newborn death that contribute to under 5 death is increasing. Percentage in parenthesis. Newborn mortality and causes. While these achievements in under 5 and infant mortality have been notable, there has not been a proportional decrease in newborn mortality rate, probability of dying within the first 28 days of life. This has translated to a larger proportion of newborn now representing death amongst under 5 children. In 2014, newborn death were estimated to account for 61% of total under 5 death compared to 37% in 1990. Between 1990 and 2014, there was a 57% reduction in the neonatal mortality rate from 53 to 23 deaths per thousand live birth. However, when compared to more recent period, only 30% reduction has occurred since 2006, 33 newborn deaths per thousand live birth, which include a period of stagnation of the neonatal mortality rate between 2006 to and 2011. In Nepal, an estimated 12,975 newborn deaths occurred in 2013. Of these deaths, the primary cause of newborn death was preterm birth complication, 31%, followed by intrapartum related event, birth asphyxia or birth trauma, 23%, and newborn infection including pneumonia or acute lower respiratory infection and HIV/AIDS including sepsis, tetanus, pertussis and other newborn infection, 19%. The estimate for preterm and intrapartum causes are comparable to observed data collected from the tubal. Here we can see on the percentage of various newborn death. Acute lower respiratory infection 4%, intrapartum 23, newborn infection 19, prematurity 31, congenital anomalies 13%, diarrheal diseases 1%, other communicable perinatal and nutritional condition 8%, other 1%, acute lower respiratory tract infection 4%. Distribution of cause of newborn death in 2013, WHO 2013 estimate. Hospital in Nepal 2000, where the major cause were found to be infection 40%, preterm complication 30%, and intrapartum complication 23%. An analysis of newborn mortality by specific cause between the period of 2000 and 2013 showed that greatest reduction that have contributed to the overall decline in the newborn death have occurred in intrapartum related events, 66% reduction, sepsis, meningitis or tetanus, 66% reduction, and preterm birth complication 43% reduction, indicating that improvement at the time of labor, including clean picture, have greatly contributed to reducing the incidence of newborn death. Here we can see time trend of a specific cause of newborn death in Nepal. Time trend of a specific cause of newborn death in Nepal. Since 2000, there has been a marked reduction in the newborn mortality due to large reduction in the incidence of intrapartum related event, newborn infection, sepsis, meningitis or tetanus, and preterm birth complication. Reduction percentage of specific cause between 2000 to 2012 given in a parenthesis, WHO 2013 estimate. The rate of stillbirth in Nepal is also on the decline, from 29 to 18 stillbirth per 1000 live birth. Stillbirth and live birth estimated for 1995 and 2015 respectively. During the past 2 decades, there has been a 38% reduction in the stillbirth rate. The incidence of stillbirth of total newborn death was found to be 38% in 2013. Verbal autopsy study conducted in 6 representative districts of Nepal. The majority of stillbirth will freeze, 73%, suggesting that many could have arisen due to complication during labor. This is corroborated by the finding that more than half of the total newborn death occurred in and around the home, 53% compared to 39% at health facility and 6% transit to the health facility. A large proportion of newborn death occur only during the perinatal period. Within the first week of life, 69% in the 2013 verbal autopsy study, 27% on the day of birth, and 42% are day 1 to 6, and 85% most current and DHS 2011, 36.5 on the day of birth, and 47.8 on the day from 1 to 6. The perinatal mortality rate, stillbirth and newborn that die on day 0 to 6, has also declined from 57 to 37 deaths per 1000 live birth between 1996 and 2011, 35% reduction. Perinatal or early newborn death is commonly due to preterm complication, include intrauterine growth retardation and prematurity, intrapartum complication, and congenital anomalies. Major reduction in intrapartum related death due to improved care provided at the time of birth is likely to have contributed to the falling PMR in Nepal. SBR and PMR 57 to 37 PMR, 29 to 18 SBR. Stillbirth trend in the stillbirth and perinatal mortality rate. Figure shows stillbirth trend in stillbirth and perinatal mortality rate. Stillbirth rate estimated by the Cousins et al. 2011 and Lon et al. 2014. Determinant of newborn mortality. Information gathered from the household interview with Nepalese women regarding past deliveries and pregnancies provided some insight into the potential determinant of newborn mortality. See in Annex 1. Young women under 20 years of age from rural, low wealth background and with no education were found to have the highest rate of newborn mortality compared to the older women from the urban area with some education and greater wealth. For example, a baby from the family of the lowest wealth quintile is almost 3 times more likely to die as a newborn than a baby from the family of the highest wealth quintile, 57 and 22 death per 1,000 live birth respectively. Similarly, the incidence of newborn mortality among women with no education is more than double compared to the women with higher level education, 26 and 12 respectively. The timing of pregnancy also influences its chances of survival. Birth interval of less than 2 years have neonatal mortality rate that are more than 3 times greater than birth interval exceeding 45 years, 45 and 13 respectively. Improving the health and nutrition of women and children. While there are some improvement in the stunting rate of under 5 children from 57 in 2001 to 37 in 2014, Nepal still faces chronic malnutrition and 30% of children are still underweight. Improvement in management and supply of vaccination and mobilization of approximately 52,000 strong female community health volunteer (FCSB) have resulted in the eradication of smallpox, elimination of newborn tetanus, and partial eradication of polio, a substantial decline in malaria cases, and significant reduction in iodine, vitamin A deficiency, iron deficiency anemia, affecting large number of women and children. Further, the FCSB program has resulted in better preparedness for birth and awareness on danger sign directly related to the birth control. The achievement in the health have been enabled in part by significant changes within Nepali society. Enrollment in primary education has shot up from only 64% in 1990 to 95% in 2013, and average Nepali woman went from having 5 children in early 1990 to almost replacement level 2.3, reducing unplanned pregnancy and contributing to improved health of young women and their children. Disparities in service utilization. There are wide disparities in the utilization of maternal and child health services by user depending on their place of residence, urban and rural, ecological zones of mountain to try, wealth status, women education, no education to school living certificate, and ethnicity. See Annex 1. Over 80% of the pregnant newer women will make at least 4 ANC visit compared to just 35% of Madhesi or Muslim pregnant women. Just over 1/4 of the poorest pregnant women will use an institutional for a delivery, while over 93% of the wealthiest pregnant women deliver in institution. Also in stark contrast, over 82% of mothers with high level of education will bring their newborn for a PNC checkup within 2 days after delivery, compared to 40% of the mother with no education. While Nepal demographic and health surveys show improving trend in women education status and economic independence, gender role and relationship still play a significant role in determining women's use of SPA during pregnancy and at a time of delivery. Women have limited freedom in decision making and often need the consent of their family and husband for their own healthcare needs. These nationally measured disparities marks the underreported inequalities, including socio-cultural and institutional barriers that further exist at sub-national level within district, village development committee, and communities. Institutional delivery largely vary between and within districts. Dalit from Trai, that is Dome and Badi, are not reflected in national disclosure because of their relatively small population. It face significant socio-cultural and institutional barrier to accessing care, requiring micro-level analysis and response to reduce disparity in health outcome. Quality of care. Since the introduction of the 1991 health policy, the government of Nepal has expanded the network of health facility to remote corner of Nepal to improve access to health care with modern facility to rural population. It also encouraged private sector investment in health sector. Since 1990, there has been a remarkable increase in the number of health institutions, including hospitals. 4,027 public health posts and primary health care centers service the public across the country, 4 times the number since 2 decades. Today, there are 405 hospitals operating in Nepal. 301 of them are private and mostly concerned in urban areas centers. An impressive number of 196 academics and training institutions, 19% of which are public, and produce approximately 10,000 graduates annually. Despite the impressive gain in the number of physical facility and health workforce, delivering quality healthcare service to population remain a challenge. Primary care facility across the nation are struggling with persistent absence of health workers stuck out of drug and commodities, poorly maintained infrastructure and equipment, insufficient opening hour, and insufficient control of hazardous waste and basic infection practices. the large referral hospitals are further challenged by increasing demand for services by people and by passing of lower level of care, especially for maternity services. The quality of care in newborn health. The government progressive expansion of facility, birthing center, BUNC and CUNC that support 24-hour delivery, coupled with the mobilization of increased number of SPA to such facilities and incentive to drive demand for institutional delivery, has resulted in more than half of all live births now occurring in institution, 55.2, compared to just 17.7 in 2006. As the barrier inhibiting access are progressively reduced, closer attention now is required on the quality of care being delivered. The need for better quality of care in maternal and newborn care services is evidenced by recent research and assessment of 131 representative public and private birthing centers across Nepal conducted in 2014 found that only 5% of birthing centers were fully compliant with the Safe Motherhood Program guideline 65-69 in the minimum requirement for infrastructure, equipment, basic furnitures, essential medicine and supply for infection prevention. Only 57% of the health workers assigned to the birthing centers had received SPA training. Just 53 and 44% of the health workers overall had received pre-service or in-service training in delivery services, including the management of complications and newborn care services within the last 3 years respectively. When the health workers were clinically assessed on newborn resuscitation, only 66% of them correctly resuscitated or demonstration newborn model neonatally after 2 ventilation attempts. However, even with skilled health workers present, many birthing centers were found not to be adequately equipped to perform newborn resuscitation. During observation of live deliveries, all health workers wore sterile surgical gloves during the second and third stage of labor. However, only 63% washed their hand with soap and water or used an alcohol hand rub before conducting physical examination. A survey of 17 public and private hospitals in Kathmandu in 2013 indicate that there is a there is a general poor practice of infection prevention. The hospital were found to have a shortage of infection control staff and fundamental equipment, including personal protective equipment, inadequate practices of basic techniques such as standard precautions, inappropriate use of surveillance result, improper disinfection and sterilization method. It may not be a surprise then that an investigation at the neonatal intensive care unit is an urban hospital found alarming prevalence of nosocomial infection in newborn 33%, and found high prevalence of multi-drug resistant Citrobacter SBP 38% that were traced to nasal sponge. Inability to retain skilled workforce has resulted in 0.67 doctor, nurse and midwifery for every 10,000 population, significantly lower than the WHO recommended ratio of 2.3. Necessary regulatory framework to mobilize and regulate the private sector, including not-for-profit council and academic institutions, to ensure quality and equitable healthcare service remain largely unrealized. The MOSP drafted a quality assurance policy in 2009 ensure the quality of services provided by government, non-governmental and private sector according to the set standard. The implementation of the policy remained poor, and the steering committee at various levels of government with the authority to regulate health services and quality improvement committee at public facility are largely not functional. Strategic objective of the NENAP. Nepal Every Newborn Action Plan adopt strategic objectives, see figure 3.1, that are the essential blueprint for how Nepal will ensure that all newborn will have the best start in their life, informed by the bottleneck analysis, see annex 2. They are guided by the 4 strategic directions and outcomes adopted by the Nepal Health Sector Strategy 2015 to 20. They are anchored on the 9 outcomes adopted by the Nepal Health Sector Strategy 2015 to 2020, which strengthen health system function to deliver maternal and newborn intervention. Particularly, this action plan focuses on universal and access and utilization of key evidence-based maternal and newborn interventions surrounding 24 hours of labor, birth, and first few hours of life is proposed by the Newborn Lesson series. This chapter further elaborates the strategic outcome and identify key actions which will be implemented through the Nepal Health Sector Support Program Implementation Plan. Activities will be further planned and monitored through the Ministry of Health AWPB and review cycle. Care around birth and care of sick and small newborn, management of severe newborn infection, inpatient care of sick and small newborn, basic newborn care, neonatal resuscitation, kangaroo mother care, basic emergency obstructive and neonatal care, comprehensive emergency obstructive and neonatal care, prevention and management of the preterm birth, skill care at birth, CB, IMNCI, PNC, immunization, adolescents, sexual and reproductive health services, maternal nutrition, ANC, family planning, continuum of care. Rebuild and strengthen health system, improve quality care at the point of delivery, equitable utilization of healthcare services, strengthen decentralized planning and budgeting, improve sector management and governance, improve sustainability of health sector financing, improve healthy lifestyle and environment, strengthen management of public health emergency, improve availability and use of evidence in decision making process at all level. Strategic objective of the NENAP. Figure 3.1 strategic objective of the NENAP to improve equity, delivery and quality of healthcare services for all newborn. Strategic objective 1 rebuild and strengthening health system infrastructure, HRS management, procurement and supply chain management. Nepal Newborn Action Plan addresses a number of core systems that are essential and interconnected that need to function well at every level to equitably deliver quality maternal and newborn health services. This plan recognizes that strengthening the health system is accomplished by comprehensive changes to policy and regulation, organizational structure and relationship across the health system function that remove bottleneck to improve maternal and newborn health services and allow for more utilization of available resources. The Nepal Health Sector Strategy proposed a new level of infrastructure to be established across the country. The new infrastructure need to be erected that improve access to maternal and newborn services for the catchment population, particularly in districts that were affected by 2015 earthquake. Further planning for infrastructure at the local and national will be guided by the National Health Policy 2013, which call for one place, one health facility within 30 minutes of people reach for the next 5 years. This translates establishing health posts with BONC services for every 1,000 population for the Tarai. For Hill and Tarai, birthing and newborn center will be erected with BONC services. Within 2 hours of people reach and CONC services within 6 hours. New equipment and the capacity to operate and maintain them will also be required for new and already established health facility. The highest quality of care require a skilled and motivated health workforce. A challenge for the sector has been the retention of health workers in rural and remote part of the country. Thus, this action plan recognizes that innovative strategies are required to deploy and retain health workers to provide health services to underserved population, while also developing a national strategy on task shifting to ensure regular availability of maternal and newborn services is envisioned in the NHS's. Extended health worker will be deployed in the communities to deliver home-based care. Expansion of new services to be delivered from community-based care to tertiary services will require substantial capacity development measures to upgrade the skill of existing health workforce, while traditional capacity building measures, that is training, remain an important medium to impart knowledge and skill. Innovative approach such as e-learning, on-site visit and mentoring at referral training site will be expanded. Further, this action plan foresees work to improve timely procurement and distribution to ensure uninterrupted supply of medicine and communities. Key output and action: improve availability of human resource at all levels with a focus on rural retention and enrollment. Develop and implement a human resource strategic plan for maternal and newborn care that consider projection, enrollment, retention, and deployment, including for a midwifery workforce. Develop and implement job description for each sanctioned position for maternal and newborn services at the various level. Develop a locum system for CUNC terms from the regional hospital to ensure CUNC services are not discontinued, and adopt task system approach to build the capacity of health worker. For example, advanced SPA anesthesia assistant to ensure availability of trained health worker at appropriate health facilities. Improve human resource education and competencies. Improve the incorporation and implementation of CUNC, BUNC, and SBA training in the respective pre-service curriculum of MBBS, NS, and A&M program. Review and revise newborn health care training package for different health level health cardi working at different health facilities that include component on patient counseling. Build capacity of physician including obstetrician, gynecologist, and MDCP on the use of corticosteroid and tocolytes for the management of preterm labor. Review and accelerate pre-service and in-service training of health workers to include evidence-based newborn care intervention, rotation through BUNC facility, refresher training, and clinical mentoring and on-site coaching to build the competency of health worker. Provide clinical mentoring at IMCI clinical site birthing center, BUNC, CUNC site. Develop cadres of midwives. Introduce e-learning in IMNCI training to improve efficiency and the quality of training. Introduce facility-based IMNCI and establish referral mechanism for IMNCI from community to facility. Build capacity of health worker to refer cases in timely manner using the aid of partograph, and develop monitoring standard for maternal, newborn, and child health training. Develop health infrastructure as per plan and standard. Endorse standard operating procedure for newborn care services for different level of health facility. Establish BUNC site in a strategic location accessible to majority of community, which are equipped for a stabilization unit for newborn and KMC corner. Establish and strengthen CUNC site and tertiary hospital, maternal and children hospital for catering NICU services with a KMC unit, and provide ultrasound equipment and other diagnostic service to detect congenital anomalies at a zonal and high level facility. Improve procurement and supply chain management. Strengthen the coordination mechanism between division, FSD, CSD, L&D for timely procurement and distribution of supplies required for newborn and maternal health care services. Strategic objective 2. I am going to make this into the next video because my video already has 47 minutes. So thank you everyone. Please write a comment if I need to improve anything. Thank you. See you again.